Okay, good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Now, today our session is going to be on sleep medicine with Dr. Sultana. Dr. Sultana is a pediatric sleep medicine specialist trained in general pediatrics and adult and pediatric sleep medicine. She is an associate professor in the Department of Internal Medicine, and she completed her pediatric residency at Texas Tech University Health Sciences Center in El Paso, Texas, and her sleep medicine fellowship from Baylor College of Medicine in Houston, Texas. Dr. Sultana has research interests in sleep apnea and obesity in children, insomnia and behavioral problems in children, narcolepsy, circadian rhythm problems, and parasomnias. Now I'd like to request Dr. Sultana to please begin today's session. Thank you.
Thank you so much for inviting. And let's start talking about sleep. Whenever I talk about sleep, I like to talk about what is sleep and why it's needed. So I will be switching between two PowerPoints. So let us start with talking about what is sleep. Sleep is in a condition which is associated with decreased motor activity. We are not moving our muscles as much. Decreased response to environment, which means that we are not responding to the environment. And if we are sleeping, as compared to we are awake, our response to environment is low. It usually happens laying down. Obviously, we cannot sleep standing up. Very difficult. It is reversible. So that is a big difference between a coma and a sleep that we can reverse this. So why is sleep needed? We can utilize 24 hours and be very productive and do things we need to do, especially if we are in high demanding professions or very busy personal lives. Why do we need to even sleep? Sleep is actually required for every part of the body. There are different functions our body is doing when we are sleeping. For example, sleep is divided into two big groups, slow wave non-REM sleep and REM sleep. So slow wave non-REM sleep it has three stages: shallow non-REM 1, non-REM 2, and very deep stage of sleep, which is non-REM 3. So in non-REM 3 sleep, there is growth and restoration of the body tissues, the body cells which are died, body cleans them, regenerate new cells, and it controls other aspects of the body like thermoregulation, um, immunity, all other things. But most importantly, it controls our body hormones and it controls memory. REM sleep is the part of the sleep where we dream, and this sleep also plays a very important role in memory consolidation. So if you think of kids, small toddlers, babies, they sleep a lot, and their tendency of learning is very high as compared to elderly people because they are sleeping, but they can't recall the stuff. They cannot make new memories because they're not getting into stage 3 sleep. They're not getting enough REM sleep. So sleep plays an important role in our body functions, and every cell in our body needs sleep. And usually I use an example of an expensive car and a refrigerator. So refrigerator works 24/7 for years. But if you buy an expensive car and if you go to work, bring it back, take good care of the car will last longer. Otherwise, the car will have more, what do you call, miles on it, more wear and tear, and that will result in wear and tear in the car. So we are kind of expensive cars. We are not refrigerators. So that's why we need sleep. Okay, let's get started here. Okay, so we will start with talking about what is obstructive sleep apnea. First of all, obstructive sleep apnea is associated with the snoring. So you can think of how common the snoring is. Like there should be one or two persons in your family who snores really loud. So, but not a lot of people are diagnosed with obstructive sleep apnea. Not a lot of people think that snoring is abnormal, or it can cause any abnormality, or it can affect the body in any way. So sleep apnea is very underestimated. About 75 to 80% of the cases remain unidentified. And it affects the quality of life, and as well as it increases the incidence of a lot of diseases. I have listed few here, but if you start thinking about from head to toe, every disease process is kind of accelerated with sleep apnea because body is not able to regenerate itself, not able to rest. So it accelerates every disease process. I would say that other than fractures from sports, everything can be worsened with sleep apnea. And as you can see, there is a lot of untreated sleep apnea can cause a lot of cost to the medical system and as well as for the patients. So basically, sleep apnea is defined as repeated episodes of upper airway closure, and this is something which I got from internet, and I really like this description. So it means that the airway should be open when we are sleeping, and the air should pass through nose to the back of the throat to your airway to the lungs without any problem. And it's a simple picture. It is more complicated. What happens? What is a simple picture that the tongue may fall back and close your airway when you are sleeping. And there can be an obstruction anywhere from big nasal turbinates and nasal congestion. In children, big adenoids, big tonsils. In adults, large tongue. All these things can result in airway closure because when we are sleeping, our muscles are relaxed. And then when the muscles are relaxed, there is no tone and the tongue can fall back and close the airway. So what's going to happen? It's not like we stop breathing. The brain wakes up and opens up this airway, and then the brain goes back to sleep. We lose our muscle tone again. The airway closes again. The brain wakes up, opens up the airway, and this goes on and on throughout the night. So, as I said, it is very underdiagnosed. So, the prevalence we know is not as correct. So, you can see 24% of adult men and 9% of adult women can have sleep apnea, but actually, it is more common than that, and it is underdiagnosed. The most important thing is to understand that increasing rates of obesity has a lot to do with increased risk of sleep apnea. Because imagine when we start gaining weight, the fat deposit in our neck, in our tongue, and it makes the airway narrow. A narrow tube can close easily, so that results in closing of the airway with weight gain. So, as we discussed that persons with sleep apnea have narrower airway because of obesity most of the time. Most of the time, the closure is at the retrolingual, retropalatal regions. Now, in obese patients, the pharyngeal size is reduced due to fat deposition. Now, in turn, sleep apnea or OSA can in turn predispose to obesity. So there is a bi-directional relationship, but we know what started first. So we start gaining weight gradually, and it can be a physiological process with aging, with access to food. So people start gaining weight gradually, and that can cause narrowing of the airway, that can cause sleep apnea. And sleep apnea in turn causes obesity. So it increases the caloric intake. It imbalances the hormones which control our appetite. So, for example, ghrelin is a very strong hormone, and it makes us hungry. So when we are sleepy and tired because of sleep apnea, the ghrelin levels goes up, which cause us to eat, and then when we are tired, we don't feel like exercising. And if you are tired and sleepy, what would you prefer to eat, a donut or a salad? And most of the time, it's donut nor salad. So when we are tired and sleepy, it's difficult to make good choices. It's because of the ghrelin, and that also results in insulin resistance and diabetes. So more sleep apnea causes obesity, causes sleep apnea causes obesity, and it's a bidirectional relationship. So this is what actually is happening. Sleep onset, decreased muscle tone, airway closes, hypoxia or hypercapnia, or increased CO2 levels, which causes an cortical arousal. It's not important that the patient wakes up, but the brain wakes up, because brain is still working, although it is supposed to work at a very minimal level, but it has to maintain our breathing. So brain wakes up, it's a cortical arousal, obstruction is released, and then the brain goes back to sleep, and there is a decreased muscle tone. So this is the cycle which happens with people with sleep apnea. And the clinical features, let's just start with the nighttime symptoms. So first is snoring. When the airway is narrow, the air is passing through that narrow passage, and narrow airways, and that makes that snoring sounds. So loud snoring, and sometimes the airway can be closed completely, and that can cause a pause in breathing. So family members can tell the patient that they are having pauses, or they can themselves wake up coughing, choking. Their sleep is very restless because their brain is waking up, they're shifting and trying to get it to comfortable position. They start sleeping on their stomach because they want the airway to be open. Now, one thing which is we don't think very commonly associated with sleep apnea is increased visits to restroom or washroom, increased urination at night. And it is because the breathing wakes people up. When they wake up, they feel the urge to use the restroom. And it also changes the abdominal pressure and increases the urination at night. Now, that results in very, very fragmented sleep and loss of oxygen, like we mentioned. So the daytime symptoms include more early morning headaches because the patient didn't sleep well, sleepiness, unable to concentrate, work-related mistakes, roadside accidents, mood issues. They're very unhappy because we are not refreshed, and falling asleep during routine activities, especially roadside accidents, can be caused, or work-related accidents can be related to sleep apnea. So the common physical findings you will see, actually, I will just not go into the details because there's a lot of medical terminology used, but think of someone who has a small mouth, a small chin, or someone has large tongue, big neck, or those people are more prone to have sleep apnea. Long-term health consequences of sleep apnea are include everything. So the first thing is increased mortality. What it means is if the people have sleep apnea, their chances of dying due to any reason are higher as compared to people who do not have sleep apnea. So sleep apnea affects every part of the body. As we discussed, that it can result in motor vehicle accident, occupational accidents, and reduce the quality of life because we are not feeling refreshed. The loss of oxygen or desaturation results in that wear and tear we were talking about, that results in breakdown in tissues and accelerates the disease process. So it can result in systemic hypertension. Hypertension is increased blood pressure. If someone is taking 2, 3 blood pressure medication and their blood pressure is still high, that can be related to sleep apnea. Pulmonary hypertension is the hypertension within lungs that is very associated with, commonly associated with sleep apnea, abnormal heart rhythms, coronary artery disease or heart attacks, and congestive heart failure is also, they're all also related with sleep apnea. Stroke, because once we read the sleep studies, you won't imagine, but some people have their breathing stopped for a very long time. The longest I have seen was like more than a minute. Their breathing is blocked, and then they take 2 breaths and then they breathe. I'm not saying everyone has this severe sleep apnea, but I'm saying that some people can have very severe sleep apnea, and that loss of oxygen for that long can cause heart attacks, can cause strokes. So that can result in strokes. As we discussed, it causes insulin resistance. It causes increased risk of diabetes, type 2, and obesity. It also increases the risk of cancers. So our genes have a tail which is protective, and people who are sleep deprived, the tail of the genes or the chromosomes become shorter and increases their risk of getting exposed to every kind of cancer. So the risk of cancer is high, and there are other diseases such as dementia or memory problems, such as anxiety, depression, panic attacks that can be associated with loss of oxygen and sleep apnea during sleep. There can be uh, diseases associated such as reflux, kidney problems, vision problems. So you name a disease, it's a systemic disease, it will be associated with sleep apnea. So as you can see, the disease associated with sleep apnea and the percentages happening in people who have sleep apnea are very high. I will skip these details and I will get into these definitions. So when we do sleep studies, we talk about apneas and hypopneas. And we talk about apneas are complete cessation of breathing, and hypopnea are partial occlusion of airway, so this partial occlusion of breathing. And we count the number of apneas and hypopneas, divide them by hours of sleep, and that is called AHI. So whenever we talk about sleep apnea, we talk about AHI, and AHI more than 5 events per hour means somebody has sleep apnea. So if you're sleeping and our breathing is interrupting more than 5 times an hour, our AHI is more than 5 times an hour, that results in that is called sleep apnea. And more than 30 events per hour is severe sleep apnea, because that means someone's breathing is interrupting every 2 minutes. And it can associate it with excessive daytime sleepiness, sleep fragmentation, presence of arrhythmias, and that can result in more symptoms even if someone has mild sleep apnea. So who should be screened for sleep apnea? Patients who have obesity, obviously, patients who have a family history of sleep apnea, retrorrhea or a small chin or depressed chin, someone who has a treatment-resistant high blood pressure, someone who has atrial fibrillation or abnormal heart rhythms, diabetes associated with obesity, and someone who is in high-risk occupations such as pilots or bus drivers or truck drivers. They should get screened for sleep apnea. There are some questionnaires we use for sleep apnea, such as Berlin question is a very stop bang questionnaire is very commonly used in medical practice, and it has 2 words, stop and bang, and it has 8 items. So S starts for snoring, T is for tiredness, O is for observed apneas or pauses in breathing, and P is high blood pressure. Bang is elevated BMI more than 35, A is age more than 50, N as is neck circumference, and G is gender male. So if someone has 3 out of these 8 risk factors, their chances of having any severity of sleep apnea is 84%. It means 84% with 3 or more risk factors will have sleep apnea. Now, if you think of someone who is more than 50 years of age, has elevated BMI, and is male, that is 3. So male, more than 50 years with obesity, they are 84% of them will have sleep apnea. There are other screening tools we use. Then we diagnosis. So how do we diagnose these patients? It's not a clinical diagnosis. We have to do a sleep test. And there are 2 kinds of sleep tests. One is done in the sleep lab, and that is called polysomnogram or sleep study in simple words. It's a gold standard test. Either we send the patient to the sleep lab and we put a lot of wires on them. We monitor their EEG, we monitor EKG, we monitor their muscle tones, we monitor their snoring with a mic, we monitor their eye movements, we monitor their breathing, we monitor their chest movements. So and then their leg movements are recorded, and then we made a video when they're sleeping. So they are monitored from head to toe, and we know how many times their breathing is interrupting, and then we can figure out if they have sleep apnea or not. I would like to go back and show one of the polysomnogram. So I have a picture of polysomnogram. This is the breathing part. So you can see these waveforms are the patient's breathing, because the nasal cannula or the airway monitors the air coming in and out of the nostrils, and it makes this nice waveform pattern. And you can see this patient's breathing is kind of getting reduced, and then he takes big breaths, and the breathing gradually goes down, and then he takes big breaths. And these are partial occlusion of breathing, and these are called hypopneas. So going back to our diagnosis, so Either we can do the sleep study in the sleep lab, or we can have a home sleep test. Home sleep test is done at patient's home, and it is not as detailed as the in-lab sleep test. And what we do is we do not monitor their brain waves. We monitor their breathing. We monitor their body movements. So this one is kind of a screening test. Right? If you ever had sore throat and you went to urgent care, they may do a rapid strep test. That's a screening test. So if the screening test is positive, it means that patient has that disease. So if the home sleep test is positive, it means the patient has sleep apnea. But if the screening test is negative, because screening tests can miss mild cases, then we have to confirm the diagnosis with the confirmatory test, which is throat culture in a rapid strep case, and here in sleep apnea, it is in lab sleep study. So if someone has home sleep test which is negative, we do in lab sleep test. So it's very high probability, and sorry, if someone has very high probability, like they have very high chances of having sleep apnea, we can do home sleep testing. It's cheaper, it's faster, it's comfortable for patient because they are sleeping at their own space. They feel it's easy to sleep in their home, and they do not have lots of wires, so it's easier to use. Um, so the treatment. So this is how we do the diagnosis. Let's move on to the treatment. So in treatment, always think of behavioral modifications, lifestyle changes comes first, then any treatment option, and they are better than any treatment, any medical treatments, because they are preventive measures. So anything which can cause the airway to collapse or the muscles of the airway to relax, such as alcohol, because that causes sedation, so it puts us to sleep, or medications such as opioid, pain medications, benzodiazepines, they all relax the muscles and they put our brain into deep sedation. So brain cannot respond to the breathing impairment and muscle relaxants. So if someone has severe sleep apnea, we try to avoid all these medications. Then sleep hygiene is very important. There are 7 to 8 hours are suggested for adults to sleep, but you may know a lot of people, especially teenagers and young adults, that they are not sleeping enough hours. It can be studies, it can be work related, it can be social media related, but people are not getting enough hours of sleep. And whenever we are talking about sleep, we are talking about two things. Either we are talking about sleep quality and sleep quantity. Sleep apnea is poor sleep quality, but sleep quantity is how many hours you are sleeping. So if someone's sleep quality is poor because of sleep apnea, if they sleep longer, it can make up for the poor sleep quality to an extent. So we ask them to sleep at least the required amount hours of sleep. And then obviously we talk about the weight loss for patients who have obesity. It's just remember that obesity is not an lifestyle choice most of the time. It is considered as a disease now, and we offer treatment options to those patients. If someone has nasal congestion, we treat their nasal congestion because obstructive airway in the nose and the pathway of the air is blocked, and that can result in worsening of sleep apnea. We also tell patient to sleep on their side and to avoid supine position, because the airway can be, that the tongue can be pulled due to gravity. So sleeping on the side is better. Then the main treatment option is the PAP therapy. So a PAP therapy or the CPAP therapy is some of you may have seen it. It has a machine, which is a CPAP machine, hose, and a mask. And what it does, it blows air under pressure. It's opposite of a vacuum cleaner. But the vacuum cleaner blows air, pulls air from the room, and the CPAP therapy takes the room air. If there is no oxygen, they take the room air and push under pressure, and it keeps the airway open like a balloon here. So the airway is open and the tongue doesn't fall back, and the airway is open and the air passes in and out easily, and the person breathes easily. There are different kind of PAP therapies. The most important is the CPAP therapy, which you may be familiar with and you may have heard. I will just move on to the second treatment option, which is the mouth guard or We call it mandibular advancement device. And this is what they do. These are kind of a mouth guards which we wear or the patient wears when they're sleeping. They're custom made by the dentist. And they have this hinge or something to adjust. And what it does is when the patient is sleeping, it moves the lower jaw forward and opens up the space here. So again, the goal is to open the space here, and that relieves the obstruction. It is very good for mild to moderate sleep apnea. It is not as effective for severe obstructive sleep apnea. Then there are surgical options available. So a very old process was UPPP, which is we because the airway is narrow and there is crowding in the airway, so we would surgically remove the uvula, part of the septal palate, shape the tongue, and create more space back there. But after 23, 30 years of experience, we realized that even less than half of the patient can get reduction in the severity. It has a lot of side effects, so we do not do that anymore, or it is at least not the first line therapy in surgical options. Tonsillectomy, nasal septoplasty are also treatment options, especially for patients who, pediatric patients. Removing the tonsils is the main treatment option for them. But even for adult patients, we can remove their tonsils or fix their, if they have deviated nasal septum, because that can also help them in reducing the snoring and tolerating the CPAP machine. Maxillomandibular advancement, what it means is if someone has depressed jaw or very small chin, what it means is they cut the jaw and put plates in and extend the jaw that pulls the tongue forward too. And this is very invasive surgery, obviously, but it can be 90% curative for people who have retrognathia or a small jaw. Tracheostomy was also done, which is we would have a slit opening in the trachea. So we are bypassing all the upper airway, and that was curative for sleep apnea. And before we had CPAP devices, that was used frequently, but not anymore, thanks to CPAP therapies. There is another treatment option, which is very common nowadays. Let me see if I can find any of the slides with that treatment option. Oh no, this is not the one. Sorry, it's taking a few minutes, as you can see, to download. Okay, so I will skip these slides and moving. Okay, so here we go. So here we go. So there is a new therapy available nowadays, which is called hypoglossal nerve stimulation. So we do surgery, and patients who do not tolerate the CPAP, this is a second line therapy. So patients who do not tolerate the CPAP, we do surgery and we place a kind of a pacemaker in their chest. And this pacemaker has two leads. One is the breathing sensor, and one lead goes to the hypoglossal nerve. Hypoglossal nerve is a nerve which controls our tongue movements, and we provide this remote to the patient. So once the patient goes to sleep, they do not have to use any CPAP or anything. They just use this remote and they activate their device. And once they go to sleep, what happens is that the device monitors the breathing from the breathing sensor, which goes to intercostal muscles. And every time the patient breathes in, it sends signals to the hypoglossal nerve, which moves the tongue forward. So again, the goal is to open up the airway here. With the CPAP, we are using air. With the mandibular advancement device, we are using mechanical force. And here we are doing it neurologically. We are stimulating the tongue through the hypoglossal nerve throughout the night. So the tongue is moving in. It doesn't move out of the mouth, but it's moving forward and backwards throughout the night. So this is the very recent treatment options we are using. So that's all. Any questions for me? I will stop sharing.
Sorry about that. Okay. So thank you so much, Dr. Sultana. I really learned a lot from your session. We can now begin our Q&A session, if you can see my slide. So our first question is, why did you choose to go into a sleep medicine fellowship?
So sleep medicine is a very niche and narrow field. Not everyone is aware of it. And I get exposure after my residency. So I was working and I got exposed to field of sleep medicine. And I was as you know, as was a pediatrician, I wanted to do subspecialization. So I thought that this is going to be um, very good choice because there is a huge lack of pediatric sleep physicians. So that was my intention. It also gives me a variety, um, and everyone is different. Somebody may like to be general pediatricians or primary care physicians. For me, I wanted to see a variety, and I like to talk to my patient about lifestyle changes. In sleep, I'm doing all of that. So I'm seeing adults too. So that is an interesting part of sleep medicine is that we can, although I have background in pediatrics, after my fellowship, I can see adults too because the fellowship trains us in adult sleep problems too. So I can see from 0 years of age till 100 years of age patients. So I have a variety of patients. Um, then it's very rewarding field. Um, Patients come very miserable when they come to see us. They are not sleeping and they don't know why they're feeling this tired and they're tired of being tired. And once we teach them their lifestyle changes, once we treat their sleep apnea, which can be easy if they go on CPAP, their life is transformed and they come back very happy, very thankful. So it's a rewarding field too. And I feel like I'm helping a lot of people. And I talk to them a lot about their alcohol use, about caffeine use, about smoking, sleeping, diet, exercise. So I'm kind of doing lifestyle medicine, which was always my goal. So those were all the reasons for choosing sleep medicine.
That's really inspiring to hear. Thank you so much. Our next question is, how do you see your field evolving in the next 5 to 10 years, like in terms of technology or treatment options?
So the field of sleep apnea is constantly evolving. There are new ways of diagnosing sleep apnea introduced, such as instead of having the whole sleep study, although they're not as good, and that's why the sleep in lab sleep test is or polysomnogram is gold standard. But nowadays there are small features like you can wear a ring and it can monitor your blood vessel tone, and that can tell if you have sleep apnea or not. Think of the technologies, the Fitbit and Apple Watch use. So those technologies are getting in the field of sleep medicine and tell us how you're sleeping, what stages of sleep you're hitting, or if you have snoring or sleep apnea or not. So that's for the diagnostic part. For the treatment too, there are more advanced machines than CPAP. They are called non-invasive ventilators. So they're highly advanced devices. Plus, people are working on other technologies such as inspired therapy or the hypoglossal nerve stimulation is a new therapy. They are working on medications. Also, remember, they are treating obesity very aggressively now, as I mentioned, that it is considered a disease and we are treating patients. And you may have heard about GLP-1 medications, and they are changing the horizon of obesity, and that will have effect on sleep apnea incidence in general population too. So it is changing. There are a lot of changes coming up, and the main goal is to make it more accessible for the patient and easier to treat.
Yeah, that makes a lot of sense. Our next question is about how you deal with like patient care and how you approach things. So, how do you approach building trust with patients in long-term care settings?
So the good part of our field is most of the patients are chronic patients. And I think the first visit is where you build your patient's trust. Um, I listen to all their problems, and sometimes they come with the same problems of being tired, feeling miserable. And I ask them a lot of questions about their lifestyle, which they think is normal. I cannot sleep without the TV on, or I have to be on the electronics. Then people who talk about I can go to sleep after drinking coffee right away. And you may have heard those stories. So we ask a lot of questions about their lifestyle. And then I have a long first session in which I talk about how each of these factors, smoking, alcohol, caffeine, drug use, or not sleeping enough, electronics, obesity, how these things are associated. And I use a lot of images with them. So it's a hour long session, and a lot of time they learn a lot. And when they learn a lot and they feel that you are invested in their care, that is the main way of building trust from your patients. And then in choosing the treatment too, I never impose on my patient that the CPAP is the best therapy. You should use CPAP. I go over with pros and cons of each therapy, and then they choose. And from there on, they have trust on you, and they are coming back happily. They see the difference in their lifestyle, in their energy levels when they make these changes, and they are very happy. As I said, it's a very rewarding field because they come back very happy. And sometimes it's a simple just providing them the CPAP, and their life changes and they come back very happy. So it's a rewarding field, and this is how you build trust with your patient, is spending time and explaining them what's happening.
Yeah, definitely. Just even something as little as just making them aware of their problems or ways they can help themselves, like, in terms of like preventive medicine and lifestyle changes. So that's really interesting. Spinning off of that, what are the most rewarding and challenging aspects of your day-to-day like work?
Rewarding aspects, as I mentioned, when the patients come back and they tell me that I have changed their life, although all I did is giving them a CPAP machine. But as people don't know how much sleep affects them, and once they start paying attention, once they start treating it, they start feeling so much better. That is the most rewarding part. The challenging part is, as I mentioned, that there is lack of pediatric sleep physicians. And although I do both adult and pediatric sleep, um, it's it's overwhelming in a sense that it is. I have a lot of patients who come and wait. So every week, one or two patients or parents will tell me that we had to wait 6 to 9 months to see you. I feel bad too because they have been suffering that long to see us. And then the sleep labs can be really booked. It can be booked for 4 to 8 weeks. So then they have to wait for the to get the sleep study done, and then to get therapy. So it's a very slow process. Although the sleep apnea is also a very slow disease, it's not like a heart attack where you have to get the treatment right away. But I feel like it's difficult to manage patients who are very disappointed with the wait time.
Yeah. That's interesting to hear that patients really have to just be adaptable, and like physicians as well, they have to be adaptable to just any situations that can come about and really just work with the patient because the patient is like, the primary primary member of their own care team. So,
Yeah.
just communicating and making sure everyone's on the same page, helpful to get like the treatment rolling. So our next question is, how reliable are home sleep apnea tests compared to in-lab sleep studies for diagnosing OSA?
So think of it, I'm not giving you exact numbers, but think of it like 70/30. So 70% of the patient who get home sleep test will have positive effect, positive result, positive sleep apnea, but 30% of the time it can miss. Because in the in-lab sleep test, we are monitoring their EEG, so we know if they are sleeping or not. In the home sleep test, we are not monitoring their EEG. So if they are staying in bed, we are thinking they're sleeping, they are not sleeping. So that can result in discrepancy. And that's why we do need to send those patients to in-lab sleep test. Other thing is that home sleep test is not established for pediatric patients. So all pediatric patients go for in-lab sleep studies.
Mhm. Someone asked in the chat, I'm not sure if you mentioned this in your presentation, how much does family history play a role in the development of obstructive sleep apnea?
It has a big role. Not only, so think of your anatomy here, like we all resemble our family members, right? So our inner anatomy also resembles our family members. So some people have narrow anatomy, like their airway is narrow, their tongue is large. Even my tongue is large, although I'm not overweight. So 30% of the patient can have sleep apnea, even if they're not overweight, and that can be because of their large tongue. We call it we assess it through Malambarti score. So large tongue can occlude their airway, and that can be hereditary. So some people can have certain features such as depressed chin or small mouth that can be hereditary. So 30% of the patients can have sleep apnea um, due to family history, and also obesity can run in the family, and that can result in sleep apnea in the whole family too.
Noted. Thank you so much. I think another question we have is, can untreated sleep apnea lead to irreversible damage and like complications, or is it always possible to like reverse those complications with treatment?
Some of the complications can be irreversible, such as um, a stroke, such as heart attack, such as congestive heart failure or abnormal heart rhythms. These things can be irreversible. But most of the problems, such as diabetes, people, when they use the CPAP machine, it has been proven through research that their diabetes is better controlled. So some of the problems can be reversible, and some of the problems can cause the damage. Also, sleep apnea can result in death during sleep. So, like I was mentioning, someone's sleep apneas were more than a minute long. Sometimes we see horrible sleep apnea. So, I was talking about AHI more than 30 is severe. Sometimes people can have AHI of 80, 100 times per hour. Their breathing is interrupting. So, those people can die during sleep, and that is very irreversible.
Yeah, definitely. Yeah, that shows us that like you have to, once you have issues with like your sleep, and you
Yeah,
have to make sure you check it out and don't like delay care,
yeah.
and make sure you keep up your preventive measures and your lifestyle just to prevent, irreversible things like death. So, thank you so much for that. Our next question is, how often should someone with OSA be reevaluated for the effectiveness of their treatment plan?
So what we do is once we provide them the treatment options, such as every treatment option has a different protocol. So for CPAP machines, we see them within 3 months, and if they are doing excellent, then we start seeing them every year. If they have dental advancement device because they are following up with their dentist, I see them every 6 months, and I repeat their sleep study with the dental advancement device to see the effectiveness. For inspired therapy or the hypoglossal nerve stimulation, they get it done by the surgeon, ENT surgeons. Then they come to us 6 weeks after, 4 to 6 weeks after surgery, and then we see them after 6 weeks, then 3 months, and then depending how good they are doing, we space out their follow-ups.
Got it. Thank you so much. Let's see here. We've got another question. Let's see. So, what is the connection between sleep apnea and mental health conditions like anxiety or depression?
So, as we mentioned, that the brain and the heart, these are the two main organs which need to rest when we are sleeping. The heart beats at a slower pace, the brain rests and goes into very deep stages of sleep. So, all layers of, like when we are awake, we are working from the all layers of the brain. When we start sleeping, each layer of the brain slowly goes to sleep, and only the core, which is maintaining breathing and maintaining the residual functions such as memory and all those things are working, but the rest of the brain is resting. So once the brain is not getting rest because of the not enough hours of sleep or very poor quality of sleep because of sleep apnea, the brain cells start getting tired. So other than a stroke, it can result in depression, it can result in anxiety, I have seen few patients which were very young in their 20s, and they presented with severe panic attacks. And what we figured out is they were having sleep apnea at night. So when they were sleeping, their breathing was interrupted and they were very sensitive to it. So the feeling of not being able to breathe, they would wake up with palpitation and anxiety. And that can even translate into daytime anxiety too. So all psychiatric problems and such as anxiety, depression, bipolar, they all can get worse with being sleep deprived and sleep apnea. And we get a lot of referrals from our psychiatrist and cardiologist colleagues.
Yeah, that makes sense. I mean, it also explains why people who like don't sleep well, tend to face these issues and why people always, advocate for getting more sleep and,
Yes.
staying off screens before bedtime, all that stuff.
I would
So
like to
you
add one
touched
more thing
upon.
here. Is in children, ADHD is very common, attention deficit and hyperactivity disorder. That is very common. And in children, it is very strongly associated with sleep apnea. Even very mild sleep apnea can result in hyperactivity, difficulty focusing. For students, I actually recently did a session for my medical students, how sleep can improve their performance. And we went into deeper details of how the memory is restored when we are sleeping, and it is difficult for us to learn or anything without sleeping. So because we are talking to a lot of young students who are aspiring to become almost likely get into medical field and are studying, so if you take a small nap after you study, your brain has more chances of consolidating in whatever you have learned.
Yeah, definitely. I've heard that before. I've never tried it, but we'll see if I should start using that for the final exams. Thank
Yes.
you so much. I know you touched upon like the evolutions in your field, but I think someone else asked, are there any like ongoing studies or emerging research that you're like keeping up with that you find particularly promising in the field of sleep medicine?
I think the obesity medications are very new, and they are in near future may change the horizon of sleep apnea, will reduce the number of sleep apnea patients with controlling the obesity and all the other problems obesity causes. So I am focusing on that. There are always efforts to have simpler therapy for sleep apnea, such as taking a pill just like any other disease instead of dealing with the CPAP. CPAP is excellent, but some people may not tolerate the mask and putting the device on every night. So there has been work going on finding medications which can help with sleep apnea.
That makes sense. We're looking forward to how research has plays like such a big role in every field, and hopefully it all works out for the best. So, someone asked a question about interdisciplinary collaboration. Like, how do you work like in your day-to-day life with other specialties, other specialists to optimize patient care?
So sleep is very interdisciplinary field. First of all, anyone who has done a residency can do sleep fellowship. It's a 1 year fellowship. So even a cardiologist can do it. It's not only for pulmonary critical care physicians, primary care physicians such as internal medicine, family medicine, pediatrics, they can do it. So it's very interdisciplinary field. It deals with psychiatry because it deals with insomnia, it deals with the cardiology because it deals with arrhythmia. So we collaborate with almost a lot of other colleagues, such as cardiologists for patients who have heart problems and sleep apnea, pulmonologists because they can have breathing problems, COPD, or all those kind of things, and sleep apnea that can be very worsen their condition, psychiatrists because of insomnia and depression and anxiety. We work with ENT, and because of the surgeries, tonsillectomy and other surgeries, we work with dentists because they create the dental advancement devices. We work with endocrinology because they help patients with obesity and diabetes. And we work with the nephrologists because they send their patients who have aneurysms, nocturia, to get their sleep apnea treated. So, as I said, every field is integrated into and work with sleep medicine.
That's really interesting. I was surprised to hear about like dentistry, although it does make sense, and nephrology. That's interesting connection I didn't realize. So thank you so much for that. We have a question for students who are like, let's say, doing a shadowing experience under a sleep medicine specialist. What would you like suggest to them? Like, make sure you see this or make sure you observe this and like reflect on this specifically.
What I would suggest is whenever somebody is shadowing with me, I have medical students, residents, fellows. I focus on one thing is they should get benefit on how sleep is going to affect them. They I focus and make sure that they learn how sleep is affecting themselves, and how sleep is affecting their learning, and what things they can implement in their daily life to improve their sleep hygiene, sleep routines, and they can pass it on to other people. So as a shadowing student, obviously you're not going to go and treat the sleep apnea patient directly, but these are the very good techniques you can learn. So like the sleep hygiene tips I provide to patients with insomnia. A lot of medical students really like those and implement in their own practice and their own lives too. So learn what will benefit you, because sleep is important for everyone, especially for students, for athletes, and everybody. So try to focus on what things you can implement for yourself and for your family members.
Yeah, definitely. That's really great advice. Someone else asked, how competitive is your fellowship and what can students do to stand out when like applying?
The truth is that fellowship is not very competitive because it's not a high earning fellowship such as cardiology or gastroenterology. It's one of the lifestyle medicine fields. So it's not on the higher end of paying, so it's not very competitive. It's easier to get in. Other good part of it is just 1 year fellowship. um, what was the second part of the question? I'm sorry.
Yeah, what can students do to stand out like when applying?
Doing in for any field, not only for sleep medicine, for any field, if during medical school you are doing, or during residency, because this is a fellowship, not residency. So in medical school or in residency, if you have done some research, that will um, be very good on your application, and that is true for any field you're applying for.
Yeah, that makes sense, definitely. We all just, especially even from applying to medical school, it's like you have to just be the best version of yourself and just really understand your passion and like the pathway that led you to that moment, just to make sure that you are fulfilled in your career that you've chosen for yourself. So definitely thank you for that advice. Let's see, what else do we have here? Mm, yes. Okay. So what's one piece of advice you wish you'd known as a medical student? And is there anything you would have done differently in your career path?
The importance of sleep. Obviously, when we are young, we don't feel the importance of how our body suffers when we are not sleeping. And one important message I would like to convey is to pay attention to sleep, because it is considered now a vital sign. And most of us are not getting enough hours of sleep, and that can affect our future selves.
Absolutely. That's like one of the key points, honestly.
Yeah.
So let's
Sleep.
see here. Um, so how do you manage your work-life balance?
Sleep medicine is, as I said, the lifestyle medicine field. So it is a very flexible, and we get time to do sleep studies, so we don't have to see patients like from 8 to 5, and that gives you some time um, to stay out of clinic. And sometimes I can work from home. I can read sleep studies from home, so that gives me a big benefit. When my kids were younger, I was able to take my laptop wherever they would go, and that was very helpful. I was always available for them. That was one of the reasons I did sleep medicine too, to have that work-life balance, be present for my children. And now, as my children are older, I am getting more involved in work, in teaching, and teaching medical students and residents and fellows and about sleep medicine.
That's really nice and very convenient because, technology I think after COVID, especially most people who were not working from home before started working from home and started realizing that it's a lot more convenient sometimes to be in that situation. But I know that, like, sleep studies, it's really convenient and helpful that you can sit at home and do
Yeah.
and address those and still be involved with your patient's care. So,
A
yeah.
lot of fields are not in medical medicine. Lots of fields you cannot do from home. Work from home is not impossible.
Exactly. Yeah, you have to have that human like connection that you can't replace ever. So sort of based on that, what role do you think artificial intelligence or like machine learning tools will play in like let's say analyzing sleep study data, for example?
They're already in place. So and there are softwares available which can score the sleep studies and which can score the home sleep studies. Obviously, they're not perfect, and we have to review the studies by ourselves. But it will get better, and it will take jobs away from people definitely. Um, the other way the AI is working is there are softwares available who can help people in doing therapy for insomnia, cognitive behavioral therapy for insomnia. So these are the things which are in pipeline, and they will get better and better.
Yeah. I'm not sure if you've mentioned positional therapy for sleep apnea in your presentation, but someone asked, what did they ask? Positional. Okay, so someone asked, what are your thoughts on the effectiveness of positional therapy devices as a standalone treatment for mild cases of sleep apnea?
So yeah, it was mentioned, although I didn't touch upon it. It
Mhm.
was mentioned in one of the slides. So sometimes people have more positional sleep apnea. Like their sleep apnea is very prominent when they're sleeping on their back. Not for everyone. Some patients can have sleep apnea in every position. So patients who have positional sleep apnea can use positional therapies. And positional therapies are like you can have an kind of an alarm or on the back of your shirt, or there are the old fashioned thing was to sew a pocket on your shirt and the back and put a tennis ball in it, so it doesn't let you turn it. All I always thought that it is going to be painful, and it is not as reliable. So definitely, it is not proven as a sole therapy for sleep apnea, even if it is positional, because nobody knows if they get on their backs during sleep, and nobody can control it unless they are interrupting the sleep a lot.
Definitely, yeah. That's really interesting how these kinds of treatments are so like creative in a way because I've never heard of having the ball and it's really interesting to hear about just how many things are out there to just help patients. Let's see. Someone else asked, what is the relationship between untreated sleep apnea and the progression of neurodegenerative diseases like Alzheimer's?
Yeah. So it's now we know through research that it has a lot to do with memory problems. One of the biggest symptoms of sleep apnea is memory problems, blanking out on words, forgetting names, forgetting words.
Mhm.
Because as we mentioned, that the sleep plays a huge role in our memory consolidation, in keeping our brain restful and young. So people who have sleep apnea, especially because it takes years for people to get diagnosed, and some people don't get diagnosed, so it kind of accelerates the process of memory loss and dementia and Alzheimer's. So it is very well established relationship between untreated sleep apnea and progression of dementia and memory loss in patients. When patients are younger, using the CPAP helps them with memory. One of the patient interestingly told me that his spellings are improved and he can spell things after using the CPAP therapy. That was new for me. But the memory can get better. But if you are at a certain age, with very advanced age, and it can result in irreversible damage to brain, and then maybe CPAP won't be even helpful.
That's really interesting to hear. Thank you so much. I think that is okay. So we have just one more
Okay.
question. So you know how like there's issues with cultural and socioeconomic factors in patients who are trying to receive care but are sort of have like barriers to care. So have you had like experience with involving with public health initiatives to raise awareness and improve access to care for sleep apnea patients?
So I am personally not doing anything with public health because of lack of time.
Mhm.
My goal is to increase the awareness about sleep among physicians, because even a lot of physicians are not very aware of sleep problems and importance of sleep, although younger physicians are, because it is something which has been introduced and in last 20 years and is getting more and more popularity and awareness. But physicians who are very experienced, they may not have a lot of experience with sleep. So my goal is to raise that awareness among medical students, among the residents and fellows. So once they become physicians, they are able to ask their patients about their sleep problems. Because if you don't ask, the patient is not going to know or tell you about their sleep problems.
That's really great to hear. Yeah, it's like physicians like you who volunteer their time and who actually care about people and about advancing the field of healthcare is how, medicine just evolves over time. And it's just really refreshing that you're here this morning to share awareness basically with the people who are watching. So thank you so much for your time. And those are all of our questions for today. We really appreciated your informative learning session for all of us. And I'd love everyone to please give a warm thank you to Dr. Sultana in the chat. All right. Now we're
Thank you
going
so much.
to,
I really enjoyed talking to you all.
thank you so much. Have a good one. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live. And again, you'll need a 70% or higher to pass and receive certification. Our next session is next Sunday, December 15th. So don't forget to join our mailing list if you haven't already, because we send all session and quiz reminders to your mailbox, and you can join from teleshadowing.com/join. So I look forward to seeing everyone here next Sunday again. Thank you so much for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.